Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense, continuing our endocrine physiology series. In my physiology playlist, in the last video we had an introduction where we talked about the genomic action versus non-genomic action. In other words, we talked about cell signaling transductions or biosignaling. So if you want to learn about the G proteins, the tyrosine kinase receptors, etc., watch the previous video. Today, it's time to talk about the anterior pituitary gland, the adenohypophysis. Let's go! Please try to watch the videos in my physiology playlist in order. Today we are here, video number 92, endocrine physiology. Let's get started. There is the CEO, followed by the general manager. Underneath, we have the employees. They are part of the company. The independent contractors really don't care that much about the company. That's the human body right there. The CEO of the endocrine system is the hypothalamus, followed by the general manager, which is the pituitary. There are three glands that listen to the pituitary, and they are thyroid, adrenal cortex, and gonads, and three glands that could not care less about the pituitary, which are the parathyroid glands, adrenal medulla, and the endocrine pancreas. How does the pituitary talk to the employees? Via hormones. So to talk to the thyroid gland, the pituitary will send TSH. To talk to the adrenal cortex, the anterior pituitary will release ACTH. To talk to the gonads, the anterior pituitary will secrete FSH and LH. This is my thyrotropin, this is corticotropin, and these are gonadotropins. Before we continue, today we'll go very quickly because most of the stuff has been discussed before. If you want a slower pace, check out my biology playlist. I have several videos on the endocrine system. Let's go. Nervous stimulation versus hormonal stimulation. Nervous, somatic, or autonomic. Hormonal is always automatic. You cannot tell your glands to secrete more or less. Shut up. Nervous stimulation, super fast, nerve impulses. But hormonal, slow. Nerves are always firing, hormones secreted only when needed. Hormones are secreted when needed in very small amounts. We measure them in micrograms or even nanograms. Meanwhile, hemoglobin is measured in grams per deciliter. Not with hormones, we're talking about teeny tiny amounts. Hormones are highly active, could be lipid soluble or water soluble, as we have discussed before, and they act via secondary messenger system like the G protein, for example. Please refer to previous videos. When a cell secretes a hormone to act on the same cell, it's called autocrine. When the cell secretes a secretion to act on the neighboring cell in the local area surrounding tissue, this is called paracrine. But when a cell secretes a hormone and dumps it directly into the bloodstream to take it to distant places all over your body, this is called endocrine. Exocrine glands have ducts, but endocrine glands are ductless. Remember the CEO, general manager, and then employees. Who's the CEO? Hypothalamus. General manager, pituitary. Who are the employees? Thyroid, adrenal cortex, gonads. When the hypothalamus secretes growth hormone releasing hormone, it goes to the anterior pituitary. Tell her to secrete growth hormone or somatotropin. Soma means body. Trope means to grow, IN, protein. Growth hormone will help you grow. Growth hormone will also go to the liver to make the loyal son of the growth hormone known as IGF-1, insulin-like growth factor 1. You know why? Because insulin is anabolic. Insulin wants your cells to grow. Also, growth hormone is anabolic. It wants your cell to grow. But when the hypothalamus secretes somatostatin, it's a universal inhibitor. It inhibits everything, including the growth hormone. If the hypothalamus secretes gonadotropin-releasing hormone, it will go to the anterior pituitary, tell her to secrete the gonadotropins like FSH and LH, and then they will go to the gonads. In females, the gonad is the ovary. Now the ovary will secrete estrogen, progesterone, and inhibin. In males, the gonad is the testis, and it will secrete testosterone, dihydrotestosterone, and inhibin. When the hypothalamus secretes TRH, thyrotropin-releasing hormone, it will go to the anterior pituitary and tell her to secrete thyroid-stimulating hormone. TSH is going to go to the thyroid gland and stimulate it to secrete the thyroid hormone, such as T4, 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 and some T3. When the hypothalamus secretes corticotropin-releasing hormone, it goes to the anterior pituitary, tell her to secrete adreno for the adrenal, cortico, adrenal cortex, tropic growth hormone, ACTH will go to the adrenal cortex and tell the zona fasciculata to release cortisol and tell the zona reticularis to release adrenal androgens. How about the aldosterone from the zona glomerulosa? Well, the aldosterone from the zona glomerulosa is not under the influence of ACTH. The aldosterone is under the influence of the renin-angiotensin system. That's why we call it renin-angiotensin-aldosterone system. Next, when the hypothalamus secretes TRH, yes, it's the same TRH as this one, it will tell the anterior pituitary to release prolactin, which makes milk. It's prolactation. But when the same hypothalamus secretes dopamine, well, it inhibits prolactin secretion. That's why dopamine has another name or a nickname. It is called prolactin inhibiting hormone or prolactin inhibiting factor. And this concludes the anterior pituitary. Let's talk about the posterior pituitary. First of all, it does not make any hormones. It stores the hormones that the hypothalamus made, and these are ADH and oxytocin from the supraoptic and paraventricular nuclei in the hypothalamus. And then when your body needs them, the posterior pituitary is just gonna dump them into the bloodstream. But the posterior pituitary did not make them. What's the function of antidiuretic hormone? To preserve your blood pressure. It wants to raise your blood pressure by two mechanisms. V1 receptor is going to constrict your blood vessels, and of course this will raise the total peripheral resistance, which will raise your blood pressure. ADH acting on V2 receptor will facilitate water reabsorption in the renal tubules, and this of course will increase the blood volume, which will increase blood pressure. Why V? Like ADH, where did you get the V from? Oh, because the nickname of ADH is called vasopressin, because it constricts vessels. I will press on those vessels, and I will press the kidney to reabsorb water. Ha ha. Oxytocin is the love and bonding hormone. It also lets the milk down from the breast to the baby's mouth. Hypothalamus releases TRH, goes to the anterior pituitary to secrete TSH, which goes to the thyroid to release T3 and T4. What if I have too much of T3 and T4? They will inhibit TRH release and they will inhibit TSH release. This is called negative feedback. What if I have little T3 and T4? This will stimulate the secretion of more TRH and more TSH from the hypothalamus and anterior pituitary respectively. You have to understand the difference between primary, secondary, and tertiary. If the problem is in the gland of concern, it's called primary. One step ahead is called secondary. 2 steps ahead is called tertiary. Let me explain. Let's say that you have low levels of thyroid hormone. Now, the question is, who caused it? All right, who caused it is the thyroid gland is toast. Okay, so the problem is in the thyroid gland. Therefore, what? Therefore, we call this primary hypothyroidism, because the problem is in the gland of concern, the gland here being the thyroid. But what if the problem is not in the thyroid gland? The problem is that the anterior pituitary is not making TSH. Oh, now you'll call this secondary hypothyroidism. But what if the problem is not in the thyroid and it's not in the anterior pituitary? The problem is that the doofus hypothalamus is not making TRH. We'll call this tertiary hypothyroidism. Easy? Cool. What if we have hyperthyroidism? Same story. It could be primary hyperthyroidism, secondary hyperthyroidism, or tertiary hyperthyroidism. The 10 Commandments of Endocrinology is by far my favorite part of the lecture. You have to understand primary versus secondary versus tertiary. And then you have to understand the difference between positive feedback and negative feedback. All right, let's start by negative feedback because it's more common in your body. If low T3 and T4 is gonna tell your pituitary to secrete more TSH, we call this negative feedback. Okay, what if we have more T3 and T4 and this tells the pituitary to shut up and release less TSH? This is also a negative feedback. Many students will look at this and say, oh, this is high, therefore positive, or this is high, therefore this is positive feedback. Nonsense. If the arrows are opposite, this is negative feedback. Low causing a high or high leading to a low, both are examples of negative feedback. But if increased estrogen release is going to increase LH, which will increase estrogen release, which will increase LH, which will increase estrogen when the arrows are moving in the same direction. This is positive feedback. An example of this is the LH surge in the menstrual cycle. My gland is hypersecreting. We have talked about this before in the pathology of endocrine system. This could be an adenoma, adenocarcinoma, or just hyperplasia. The operation manager is the pituitary, but the chief executive officer is the hypothalamus. The anterior pituitary gland makes and stores, but the posterior pituitary stores only. It does not synthesize anything. There are 3 glands that listen to the anterior pituitary. We call these the employees, and these are the thyroid, adrenal cortex, and gonads. Their secretions are usually fat-soluble, therefore slow, as we have discussed before. The 3 independent contractors could not care less about the pituitary or the hypothalamus. They are the parathyroid instead of thyroid, adrenal medulla instead of cortex, and pancreas. Some hormones will be freely floating in the bloodstream. Others will be bound on plasma proteins. Only the free is physiologically active. The bound is not active. Only the free hormones can exert physiological action, exert positive or negative feedback, or cause clinical symptoms when they are high or low. There is insulin land and there is glucagon land. All the hormones are in glucagon land. Insulin stands alone. Eagles fly alone, and insulin is an eagle. It's the land of abundance. It's anabolic. All the other doofuses are catabolic. And we have talked about the tale of 2 hormones in previous videos. Pulsatile secretions versus continuous secretions. There are 2 modes of secretion. Let's say that your hypothalamus is secreting gonadotropin-releasing hormone. We can secrete this in a continuous fashion. Secretion, 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 secretion all day long. Or we can do it in a pulsatile manner. Secretion and stop. Boom, secretion and stop. Boom, secretion and stop. The pulsatile gives you a stimulatory effect, but continuous secretions will lead to sensitization, adaptation, negative feedback. Eventually, it will not cause any activation of the target organ. Therefore, let me ask you a hypothetical question. Imagine that a kid is not growing due to deficiency of growth hormone. Should the doctor inject him with growth hormone once a day, or should the doctor give a continuous venous drip of growth hormone? Of course, if you want to stimulate the target, if you want the kid to grow, give it in a pulsatile manner. So I'll inject you today. The injection takes like 20 seconds and we stop. And then you come tomorrow. I inject you for 20 seconds and stop. This is a pulsatile fashion. It will stimulate the target organ, such as bones, cartilage, muscles, etc., so that the kid can grow. The distinction between the lipid-soluble hormones and the water-soluble hormones was discussed in previous videos in this endocrinology playlist, so please pause and review. And pause and review. Only the free is physiologically active. That's the good news. The bad news is that it's free. It's not bound to plasma protein. Therefore, it will be filtered through the kidney and you will see it in the urine. Lipid soluble, on the other hand, is usually bound to plasma protein because the blood is made of water and this is lipid. Lipid cannot float in water. You have to carry it on plasma protein. Therefore, it's not physiologically active when it's bound like this. That's the bad news. Good news, it will not end up in the urine. For the most part, of course.
But hey, medicosis, how about urine cortisol in patients who have Cushing syndrome?
Alright, you just said Cushing syndrome, right? Patients who have Cushing syndrome have too much cortisol, right? And when you have too much cortisol, you have overwhelmed the system. All of your plasma proteins are saturated. That's why cortisol will begin to show up in the urine in abundance. The ligand alone is not active. The receptor alone is not active. Only the ligand receptor complex is active. They have to hug and kiss each other in order to get activated. Therefore, pathology can hit you here or it can hit you here. If it hits you in the ligand, we usually call this type 1. If it hits you in the receptor, we call this type 2. Case in point, diabetes type 1. The problem is that you do not have insulin. In type 2, well, the insulin is fine, it's that the receptor is not listening. Same thing in diabetes insipidus. It's just different terminology. Type 1 is central diabetes insipidus, no ADH. Type 2, well, we have ADH. It's that the kidney's receptor is not listening. See, medicine makes so much sense once you understand what the flip you're talking about. Control of hormones. The hormones, of course, are under hypothalamus control. Negative feedback and positive feedback, although mostly it is negative feedback because positive feedback is explosive. And the diurnal circadian rhythm. For instance, cortisol is secreted more in the morning. Growth hormone is secreted more at night. Why? Alright, cortisol is an anti-stress hormone. Yep, most stressful situations happen in the morning because you wake up early in the morning, you go out into the world. You drive like a maniac, and other drivers will start cussing at you. That's a stressful situation. You need lots of cortisol in the morning. However, when you're sleeping at night, you're lying flat down. Therefore, the effect of gravity is eliminated. It's easier for you to grow vertically from head to toe. This is your metabolism. If I'm going this way, I'm burning stuff to get energy. Break down the carbohydrate into glucose, the protein into amino acid, the triglycerides into free fatty acids. This is called catabolism. Who's the hero of catabolism? Glucagon and his friends, which include epinephrine, cortisol, thyroid hormone. But if you're going in the opposite direction, from glucose to carbohydrate, from amino acids to protein, or from fatty acids to triglycerides, this is called anabolism. Who is the hero of this? Insulin alone. Insulin is anabolic, protein anabolic, glycogen anabolic, triglyceride anabolic. But glucagon is catabolic. Glucagon is protein catabolic, glycogen catabolic, triglyceride catabolic. Not glucagon only, but glucagon and his friends. In other words, insulin alone is in one land. All the other hormones are in the other land. How about growth hormone? Growth hormone is in the middle. It is borrowing the first characteristic from insulin and the second characteristic from glucagon. Growth hormone is protein anabolic, like insulin. It is glycogen and fat catabolic, like glucagon. What does growth hormone and prolactin have in common? They are polypeptides secreted by the anterior pituitary, specifically by the acidophils, and they use the JAK-STAT pathway as we have discussed before. I have an entire video about the JAK-STAT. If you look close into the anterior pituitary, the red squares are the acidophils, the blue squares are the basophils. As you see, growth hormone and prolactin are secreted by the acidophils. All the others, basophils. Look at this lovely growth hormone or somatotropin. It has some actions that are similar to insulin and some actions that are the opposite of insulin. Similar to insulin, protein anabolic. I want you to build up muscle. I want you to build up cartilage and bone. How did I do this? I summoned my son. Who's your son? It's called IGF-1, insulin-like growth factor 1, also known as somatomedin C, because it's the middleman of somatotropin. Tell me about your anti-insulin actions. Growth hormone. I will break down glycogen into glucose. I will help gluconeogenesis, and I will break down the big fat into small free fatty acids. This chart was discussed ad nauseum in the previous videos. Here are the effects of different hormones on the female breast. Estrogen will make the nipple and the duct. Progesterone will make the acini or the alveoli. Alright, these are empty sacs so far. Who's gonna fill them with milk? Prolactin, because I'm pro-lactation. Who's gonna let the milk down into the baby's mouth? Oxytocin. I have a video on my channel called Dopamine and Neural Pathways. If you remember, dopamine in the nigrostriatal pathway was pro-movement. If you do not have dopamine, you're not moving. If you have too much dopamine, you're moving like crazy. But dopamine in the mesocortical limbic pathway is pro-mood. Too little dopamine. I'm so sad, depressed, life is meaningless. What's the purpose anyway? Too much dopamine. Oh my goodness, life is awesome. Third, dopamine in the tuberoinfundibular pathway is anti-prolactin. If you do not have dopamine, prolactin will run amok. No one is inhibiting it. Prolactin will be uninhibited and will cause hyperprolactinemia, which will cause galactorrhea. And it will suppress gonadotropin-releasing hormone, which will decrease FSH and LH. In females, this causes amenorrhea. In males, this causes impotence and gynecomastia. In other words, impotence in males is equivalent to amenorrhea in females. Never ever forget this. Again, dopamine is anti-prolactin.
What if I have too much dopamine?
You will inhibit prolactin. Not just prolactin, dopamine hates everybody. It hates GnRH and growth hormone as well. I had a patient with schizophrenia. I gave the patient dopamine antagonists known as antipsychotics. One of the side effects of them is, well, they are anti-dopamine, therefore pro-prolactin, therefore can cause hyperprolactinemia with all of these symptoms. Let me give you another case. There is a patient who has a tumor in the brain known as pituitary adenoma. Prolactinoma to be specific. His pituitary is secreting too much prolactin. How do I treat it? You can treat it medically or surgically. Surgically is easy. You just remove it through transsphenoidal surgery. How about medically? Give dopamine agonists, something that is pro-dopamine and therefore anti-prolactin to inhibit the prolactinoma, such as the medication known as bromocriptine, capergolene, etc. Alright, keep in mind that prolactin and estrogen hate each other. Prolactin is prolactation but anti-ovulation.
Alright, I understand that it's prolactation. How is it anti-ovulation?
It suppresses GnRH and it suppresses LH and FSH. Conversely, estrogen, anti-lactation but pro-ovulation. Prolactin and estrogen are enemies. That's why when mommy is pregnant, she's not lactating. But when mommy is breastfeeding, she cannot get pregnant. Most of the time, not all the time. In fact, we cannot just rely on prolactin as a contraceptive method. At any rate, do you know why prolactin and estrogen are enemies? Yeah, easy. Because lactation and pregnancy are time-consuming, resource-consuming, very expensive and draining phenomena. That's why prolactin inhibits estrogen. Okay, I'm busy lactating right now. The baby is sucking the life out of me. Do you think I have energy to get pregnant? Shut up! So I'm gonna inhibit LH and FSH. Conversely, I'm pregnant right now. Do you think I have any energy to breastfeed? Shut up! So I will inhibit prolactin. Economics is the study of scarce resources which have alternative uses. Since the resources are bloody limited, we need to economize. And we shall continue in the next video. I have an otacoids pharmacology course on my website, as well as an endocrine pharmacology course. Learn about the different types of insulin, how to calculate the dose, etc. at medicosisperfectionalis.com. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.